Appreciate the disclaimer there. I'm Donnie Farber. I serve as the Vice President of the KLS Foundation. I am also a former KLS patient. I suffered from 17 KLS episodes over a 10-year period. Today we're gathered because this is our first call in our research series where we'll speak to the key KLS research investigators. Today we're fortunate to have Dr. Isabelle Arnulf with us, and then in October we'll do another call with Dr. Mignot and Dr. Goldstein-Pekarsky at the Stanford Sleep Center. I think most people on the call today are familiar with Isabelle Arnulf's name. She's one of the leading researchers on KLS for a long time now, but let me quickly introduce her. Dr. Arnulf holds a PhD in neuroscience, and I believe she was first introduced to KLS when she visited the Stanford Sleep Center in 2004, 2005. During her time there, she really coordinated the entire Stanford KLS research program under the direction of Dr. Emmanuel Mignot. And for the last 20 years or so, she's been the head of the sleep disorder unit at Pitié Salpêtrière Hospital in Paris. I hope I pronounced that accurately, Isabelle. And as it relates to KLS, Dr. Arnulf has seen around 300 KLS patients and is also the author of over 30 groundbreaking research papers on the subject. So given those credentials, we're very lucky to have you join the call with us today, Isabelle. Thank you very much. And just quickly before I hand the call over to you, let me just quickly lay out the format for the call. We thought it would be most valuable if Isabelle shared from her work a few things. One, what we have learned in terms of predispositions to KLS. Two, what we have learned in terms of symptoms during episodes. Three, what we have learned in terms of symptoms during non-symptomatic periods, so outside of KLS episodes. And finally, what we have learned in terms of different treatments and the observations there. We thought it made sense that after each of those sections, we'll open it up to Q&A before moving to the next. And so like Steve said, we've muted everyone just to eliminate background noise. But if you do have questions, either press the raise the hand button or put a question in the chat and we'll be monitoring those. So again, Isabelle, thanks for your time here today, and the floor is all yours.
Thank you very much, Danny, Stephen, and Geneviève for all you do for the disorder. So let's start with youth in my hospital. We'll cover the history, the predisposition, symptoms, residual symptoms, and how we could prevent episode. Just for some history, you can see the old photograph of myself, and here is Emmanuel Mignot in Stanford, 2004. At that time, I had only seen 3 cases in France, and then there was a KLS Foundation helping us to build the program on DNA. And you can see the family Farber. Then you were not there at that time when I visited you. Then I went back to France and I developed a center, sleep clinic, that benefit from the National Orphan Disease Program, and we created the French KLS reference centers. It means that almost all cases from the country should come to my center and be evaluated there, which is totally paid by the government and had helped to progress in rare disorder. So we were able, for example, to edit some national recommendation for disability rights, for example, or for orphanet. And recently we published the national program of how to diagnose and care for KLS. It's validated by the ministry, and it helps to be very homogeneous in treating the disorder over the country. Thanks to the program, I was able to follow up 300 patients with KLS in Paris. So this is to share this experience that I come today. This is my sleep clinic. We are almost 100. Only a part of them are working on Klein-Levin. Each patient comes for the first time. They come on Monday, and they are going through a few assessments. Their neurological assessment with either me or Dr. Dede, a psychiatrical assessment with Dr. Gros, And a questionnaire, you know, the KLS questionnaire I developed in Stanford, we still use it. Everybody got a FDG TEP scan and some biology, including DNA, that we sent to Stanford, of course. And we also assess the cognition of patients with our neuropsychologist. We assess the apathy, and in the last 2 years, all that has been done for the last 18 years, but in the last 2 years, we have started to study sleep out of the episode because there might be things there. Then we specify if the patient has or not Klein-Levin, and we make some counseling. We, depending on the cases, we suggest drugs, and patients come back every year at the beginning, sometimes more often if we have problem for the drugs, and we follow them until we are able to tell them that they are on remission and we can stop treatments or stop seeing them. We also take back patients for IV steroid during episodes. This concerns only a little part of patients. In other cases, I try to organize that on the local hospital, and it's not for everybody, of course. So this is how we do in Paris. So what did we learn in the last year about predisposing factors and marker for KLS? First things, we learned that it's not 1 per million, but it's rather 3 to 5 per million. It's still a rare disorder, and it means the incidence case is 0.3 per year, at least in France. We confirmed the male predisposition of the disorder. This is what I've reviewed in the last century about KLS. There were 1/3 of cases were women. In the first Stanford series, we got 24% of women. And in the French cohort, last time I looked at over 200 patients, we had 1/4 of women. And women came more after there were some TV shows, including women with disorder, because the journalists like to call it Sleeping Beauty syndrome. It's not very appropriate for KLS, but at least more women are diagnosed after the media information that women can also be affected. Still, it's more male. We can still continue to confirm that it comes more often during teenage, but there are some cases starting before 12, and there are a few cases starting late in adulthood, and these cases are more severe in terms of duration. When I was in Stanford, we rapidly saw that a lot of patients in terms of predisposition had birth difficulty or developmental difficulty, which means some being either premature or having some delay in development or dyslexia or things like that. It's 1/3 of the case, and it's much higher than what we see in controls. We confirm exactly the same figures in the French cohort. So this seems to be something true. And the second thing that started the Stanford cohort was the fact that there were a few cases where there were 2 people affected in the same family. It's not frequent, it's less than 5%. You can see the American families here, and all that are the French and Belgian families. And we have even twins, both of which being affected. It's still rare, but it's the basis why we looked on DNA first when we collected the bank in Stanford. Now, you probably have been aware of the Stanford DNA program that we started in 2004, and it took us almost 18 years to collect enough patients, 800 patients with KLS. It was a worldwide effort. And what you see here is a result of the first discovery cohort on 673 patients. Each number here corresponds to a chromosome, chromosome 1, chromosome 3. And here it's imagine that each point corresponds to a gene, and frequent is in the KLS cohort compared to 15,000 subjects without KLS. And we used to do statistics and to examine all genes that are much more frequent in careless patients than in the normal population. And we use statistics because there are thousands of genes. We need a very strong cutoff, which is usually 10⁻⁷ in terms of powers. And what you can look at is what is in the significant range. It's here. And all these genes are in the trunk 1 region in our genome, in our chromosome, and they are more frequent in careless patients than in the general population. It does not mean that it causes the disorder, but it's more frequent. It's a predisposition gene. Then that was found in the first cohort, and in terms of science, you need to reproduce a result to be sure that it's true. And the referees of our article asked us to do a second replication study. So we collected again all DNA we could have world round, and it was 171 patients more. And this first finding were only weakly reproduced in the replication cohort. This gene, TRNK1, exposed subject having it to 48% higher risk to have a KLS than the general population. The TRNK1 gene is something that repairs the DNA and the binding, and it's expressed in the brain. We were disappointed not to reproduce the first result in the second cohort, but then Emmanuel had an idea. He looked at how associated the gene was with KLS, depending on the age at birth of all patients that contributed. And if you see 1 here, means that the gene is as frequent in the general population as in KLS. And when it's above, it means that it's significantly higher than in the general population. And what you can see is that in the youngest patient, those born after 1999, the association with the gene decrease. So we wonder why was the gene associated with our oldest patient and not our youngest one. And then we looked at sharing the population between those who had or are not some birth difficulty. And this time it was more obvious that those who had birth difficulty had more frequently the genes, the TRNK1 genes, than the other ones. So in terms of what it means that KLS is promoted, not caused, but the association of abnormal TRNK1 gene plus birth difficulty. So we think that perinatal care are really improved over the recent decades. So there is no more influence of TRNK1 on KLS for those that have born after 95. So it's an association of 2 phenomena that has increased the risk in part of the cohort. It's birth difficulty plus the TRNK1 genes. Then I would like to share with you some negative results. Also, it's important, it's never published because it's negative, we should do, but because we are still on predisposing factors, let's say that we have tried to see whether KLS was associated with some metabolism disorder, like some problem with amino acids, things that you have to do a special diet to avoid. And we found normal organic amino acids in urine using chromatography in more than 100 patients in France. So it's obviously not a metabolic disorder, depending on what we eat during the time. We still, there are many suggestions that KLS could be an autoimmune disorder, but yet, until now, we didn't find any specific autoantibodies. The antibodies some autoantibodies are directed toward the brain, EA2, for example, GAT65, AQP4, NMDA autoantibodies. may cause some neurological disorders, but they don't cause careless yet. And we have tried again in more than 150 patients. It's disappointing. We have also looked on lymphocyte. Lymphocyte belong to the white cells and they have a lot to do with immunity, and they can be changed in patients with autoimmune disorders. And we have done in the last 50 patients, we have checked for phenotyping lymphocytes, and we didn't find anything abnormal too. We also sent some serum samples to a young US scientist. He's a former KLS patient. He told me he's funded by KLS Foundation, and he wants also to work on his own disorder and to find some new immune targets. So we sent from France some serum of our patient to help him. I hope that with all this effort, we may find something in the future. Some new autoantibodies are discovered every year. So each time something new appears, we have to check it on the serum bank of KLS. So no cause yet, just predisposition, having birth difficulty, being a boy, being a teenager, having the TRNC1 genes, but yet no direct cause of KLS. Now, if we still remain on markers, there have been some new findings regarding brain functional imaging. It's important because in the past, this disorder could be considered as psychiatrical, but because there are some abnormality on brain functional imaging, we know that it is a neurological disorder, So in the past, funded by the KLS Foundation, we performed some brain scintigraphy, ECT, in asymptomatic patients, in patients symptomatic, which is hard because they are exhausted, but they came back for having the scintigraphy. And we paid 15 healthy control to get the same exam. And we look at what's different between patient and control during asymptomatic phase, and what was different between symptomatic and asymptomatic phases. This is the synthesis is here. What is abnormal during asymptomatic phase, when patients are okay, is in red here compared to healthy control. It's an average of the 41 patients compared to the 51 controls. And what you can see that remain abnormal between episodes is the orbitofrontal lobe here, which may have to do or may be involved during episode with the behavioral problems that are seen, behavioral difficulties. Also the thalamus here and the hypothalamus are less abnormal between episodes on average in careless patients. But when episode starts, in addition, there are two other areas that are abnormal and abnormally functioning, the mesial prefrontal cortex. And we think this could explain the major apathy, the fact that people don't want to do anything, they just want to rest, they don't touch their cell phone, they are totally apathetic during episode. And this could have been to do with this area. And the right angular gyrus here, which belong to the posterior associative cortex here. And this area during episode is also abnormal. It becomes just bilateral during episode. It's also abnormal between episodes. And it's clearly correlated. Here you can see it. It's another way of showing it. The abnormality in the area is nicely correlated with the level of derealization during episode. Derealization is very disabling symptoms during episode. And we think it is linked to the abnormality in this area. It's part of the brain where we integrate all information that comes through our eyes, through our ears, to our hands, and they might not be well integrated, making the world around the patient unreal rather than looking real. So there are some bases, there are some brain bases for the abnormality we see in patients. So there is a consistent hypoperfusion of the temporoparietal junction that has to do with derealization. The orbitofrontal and the prefrontal cortex is affected and may have to do with the apathy for the prefrontal and the disinhibited behavior for the orbitofrontal. Thalamus and hypothalamus have to do with cognition and with sleep, so possibly they might explain why patients are sleeping that much. And some abnormalities persist during asymptomatic periods. Even if patients have no symptoms, you can see it. Now, also funded by the same grant from the KLS Foundation, my PhD, Sophie Labo, tried to do use some multimodal MRI, which is much more precise than the scintigraphy. And we were able to do it in 20 KLS patients. 12 of them accepted to come back during an episode, and they were compared to 20 paired healthy controls. The first thing we wanted to look at is the brain of a patient with KLS different from the brain of a non-KLS person? Because of the birth difficulty, for example, is there some change in volume of the gray and white matters in KLS as in CO? But no, it's exactly the same volume of gray and white matter. There has not been any loss of cells through birth difficulty or for other reason in KLS brain. So this was a good point. And the second point was to look at all we use some specific measures that's very specialized, FA, but also RTAP. And what it's studying networking. And what we found was that the special networks that goes through the corpus callosum here, on the knee of the corpus callosum in the brain, has to do with the apathy score during episodes. So this is to be published, but it's rare to find such clear correlation between apathy and these bundles here not working in patients. Now, all this is interesting in terms of general mechanism of the disorder, but it does not help us for a given patient. When we see a new patient, it's not an average of patient. We have to look whether the brain functional imaging is abnormal visibly in a given patient. So it's what we did in the last years. You can see it's published just last year. We look at all our patients that had benefit from another brain imaging that is called fluorodeoxyglucose, and it's TEP, positron emission tomography. And it's a routine test that we do in our KLS patients. Some could not get it for any reason. So we had 179 patients getting FDG TEP scan during an episode, PET scan during an episode 14 only, and all the other ones were asymptomatic, and we look at those without and with treatments. And the idea here was, could we find some abnormality that could help other clinicians to make the diagnosis of KLS, because until now the diagnosis is only based on clinical aspect. Are there some markers that could be useful for patients? And indeed, there are. In 138 patients with KLS syndrome, no treatment, asymptomatic periods, the TEP scan is visibly abnormal, individually abnormal, in the hippocampus in 44% of the patient, and in the posterior associative cortex in 62 of them. So at least one hypometabolic area is seen in 70% of the patient. And this ratio increase in young patients when we are close to the beginning of the disorder in the first 3 years, and when there have been a lot of episodes during the year before imaging. So we get now an exam that can support the diagnosis, especially when it's done at the beginning of the disorder in young patients. It also means that these abnormalities might disappear with time, because we didn't do it longitudinal way now, but you can see that patients that are not at the beginning of the disorder have less these abnormalities. So it might be a marker of the beginning of the disorder, possibly the more inflammatory part of the disorder. Anyway, it can be used now in all patients in the world, and it will give results immediately. And now radiologists are aware where they have to look for in asymptomatic patients. So here we are for the mechanism and predisposition. Time for me to stop and to hear for you. Maybe I could check on the chat. Okay, Annette, you asked about autoimmunity. I don't know if I answered totally to your question, but we have only indirect evidence. Autoimmunity could be a good direction of research because the disorder is intermittent, because it's often triggered by various triggers, including, as you know, alcohol intake, sleep deprivation, and infection, or any big stress, and that can also trigger any other autoimmune disorder. And also it affects young people, and autoimmunity is more frequent in young people. But and plus there are some indirect evidence that there are inflammation in the brain, or at least some specific areas that are suffering during episodes. But it stops here because we have no HLA associated with HLA group associated with KLS. We didn't find yet any auto antibodies, and we didn't find yet any abnormal lymphocyte in the disorder. But it's a good target to look for, and we will still continue. Then, and the last evidence for possibly an autoimmune condition is a partial benefit, it's not total, that we have with IV steroid in severe cases, but it's only partial. And I must confess, I have also done in a patient, very resistant patient with very long episode, we have tried with his consent to do some plasmapheresis. It's something you do in autoimmunity disorder. You remove the blood cells of the blood, and you re-inject some new ones. You remove the antibodies in the blood, and you re-inject the blood. So it didn't work, but it's only one case, and the guy had 10 plasmapheresis. So yet, not more evidence. Are you able to share a link to the KLS questionnaire? Yes, of course. Stephen, Danny, if you don't have it, I'll send it to you. Just keep that in my mind. Can we get a definition of birth difficulties? Well, we included premature or post-mature birth, some problem at birth, you know, using some, I don't know the name in English, sorry. When it's difficult to track the baby out of the mother, you sometimes use some spoons, or and it may make the brain suffering. That's it. The most confusing part is that different triggers for individual with duration and relapse, anything that can be a marker to this. It's a good question, Rajiv. If I understand well your question, is it because if alcohol, for example, trigger episode, it's somebody, is it always the case every time, or can the same person have some episode triggers by either alcohol or sleep deprivation? You know, it's usually all triggers, unfortunately, works in the same patient. So I don't think there is some specificity here. And duration and relapse, yes, you're right. It's very different from one patient to another. It's rather for the next session, but the problem is long duration episode. Obviously, when it's 1 week, it's okay. It's okay. It's never okay, but when it's 1 month or 2 months, it's a disaster. But what we have looked at is that usually the young people, the one who are teenagers, at the first year have more frequently some brief and repeated episodes, whereas long and less repeated episodes are more common in the adult form of the disorder. What about onset after head injury? Yes, of course, we found it. It's not that frequent, but it happens. Yes, after an accident with the horse. Yes, we had also after ski accident. Also bad headaches during episode. We will see that at the symptoms things. Head playing. Yeah, okay. Let me go back. I don't. Could pitocin have anything to do with birth difficulty? I don't know, Jenny. I don't know what pitocin is. Maybe the name of the drug you have. What about ADHD and ASD Asperger syndrome? Yes, not many, but ADHD, yes. When we compared in the Stanford series, we compared patients with KLS and healthy control. We had the same percentage of ADHD in childhood in both groups. So it does not means to be that frequent, at least. And Asperger are only 2 or 3 cases. It's not very frequent. Even autism, I would say that in my experience, dyslexia, dysorthographia, this in general are much more frequent. You mentioned genetic leaks. Any idea the likelihood of passing KLS on to our kids? This is a very good question, Ilfer. Let me go back just to show you what we have for family cases. First, it's very rare, less than 5% of cases. Then if you look at the transmission, it's rarely vertical. It means that here the father transmitted to the son, but in all other cases, you can see the same generation. So the transmission from a KLS patient to his or her children is exceptional. It's much lower than 1%. So I always explain to my patients the risk of transmitting it is very low. Pinky, you ask any link with bipolar disorder? Again, when we compared both the French and the American cohort of patients, we looked at the family history of bipolar disorder or the personal history, and it was the same as in the normal population. Even if we know that lithium is working in this disorder, it might be in KLS as it works in bipolar disorders, and that both disorders are intermittent, the similarity stops there. Plus, we have looked at the evolution of now more than 120 patients we follow for more than 10 years, and only one developed bipolar disorders. And when we looked back, the first episode of depression started before KLS. So we think it's not, there's no relationship. So Genevieve, okay, pitocin is used for, it's oxytocin, maybe. We call that oxytocin, the general names. No, we didn't ask for that, but it's commonly used. How can one be tested to see if they have the TRNC1 gene? Well, you have to send your DNA to Stanford University and to ask Emmanuel Mignot if he still will make the measure. I'm not sure he will do it in the future, because the link, but ask him, and I think he will be happy to get DNA by anyway. But giving the result individually is always complex in terms of genetics. Well, because there are rules for saying to somebody you have the gene or not, which are not the same rules are in research. Here it has been done in research. So maybe I could turn to the second part if I have answered the questions. Okay. So symptoms during episodes and their management. I've chose to speak on treatment of symptoms here. As you know, all patients have at one moment at least hypersomnia, cognitive impairment, derealization, and apathy, and there might be some social disinhibition in many of them. In contrast, depressed mood, megaphagia, hallucination, and hypersexuality are found in less frequently in patients, here in less than 40% of the patient. So it's not that common, whereas all what is in orange is very common. Now, what we know that we try to share these symptoms in terms of symptoms that are more on the neurology side and symptoms that are more on the psychiatry sides. Plus, there are symptoms that belong to both sides. We call them neuropsychiatric. The symptoms that are written in blue here are present in all patients during episodes, whereas some symptoms like headaches that can be quite high during episodes are not found in all patients, as photophobia, the need to be in the dark, or painful hyperacusia that is also seen in some patients. In terms of neuropsychiatric symptoms, derealization and altered perception are found in 99% of the patients, as is apathy, and regressive behavior, puerility, megaphagia, hypersexuality are rarer. In terms of psychiatric symptoms, depressive or flat mood can be seen. Anxiety also, patient not wanting to be left alone, being sick to the mother, and psychotic symptoms are found in around 30% of the patients. They include what we call reference IDs, which means that some patients don't like to be outside because they think that people look at them during episodes, people and stranger people look at them, and maybe not in a good way, like a feeling of an hostility of the surroundings. And this is a symptom that is known in psychiatry, but can be very weird for the patient. So it's one of the reasons we recommend not to bring the patient in a supermarket or downtown during episodes, because they really feel not well at all. Hallucination can happen, but they are usually very fleeting and not very marked, and delusion can happen too. So if I just go to hypersomnia, we see it mostly during the first episodes in young patients, and mostly at the beginning of an episode. Most patients sleep a lot. It's hard to wake them up. Sometimes some will say that they had a lot of vivid dreams, and the dreams seem so real that they seem more real than reality. And some people may wake up in the middle of the night because there seems to be some clock problems during the episodes. And some patients have a more alert period in the end of the afternoon, when it's possible to communicate a little with them, and then they go back to bed. And again, they have the hypersomnia. So the hypersomnia is less common in adult patient episode. It tends to decrease with episodes and to evolve towards a major exhaustion, and rather a need to rest with no major sleep excess, but a need to rest in lying often in a dark room and being inactive, rather than sleeping, just being alone, like somebody who has a migraine. But when sleep time decreased across the episode, it may unmask the other disagreeable symptoms, such as derealization and mental slowness. So some patients prefer the episode with a lot of sleep because they feel less the other disagreeable symptoms, and also they have it makes times passing more quickly. So the recommendation is to let patients sleep and rest as much as needed. We have tried a lot of stimulant, modafinil, methylphenidate, pitolisant, sodium oxybate, which we commonly use in narcolepsy, but no one of the four help until now. So it's better to sleep. As I said, sleep is not a single problem, it's a disorder. If you remove sleep, you have still the other symptoms. If patients prefer darkness, let the curtain closed, avoid noise. There are problems when patients are put in the hospital because in hospital their need for sleep is not respected and they might be sleep and rest deprived. So it increases the patient painful feelings, and increase the behavioral problems and the irritability. So we recommend not to bring the patient to the hospital unless there is something serious, and serious problem have to do with depression and suicidal ideas and with delusion. So if possible, keep patient at home during episodes. And at the end of the episodes, especially at the beginning of the disorder, there is often 1 or 2 nights with short sleep rather than insomnia. We have found with time that it is a good point. I call it the stop signal. It means that the episode is finished. Because in other cases without insomnia at the end, usually the other symptoms tend to disappear slower after the end of hypersomnia. Apathy is the second more frequent symptoms. It means no more motivation. All that people like to do, especially teenagers, like being on their smartphone or seeing their friends or I don't know, putting makeup, things like that, smoking, doing basket, it stopped during the episodes. Especially, I call that the cell phone signs. At the more severe episode, the cell phone is even not charged. With time, across the episode, some patients charge their cell phone, but they don't look at it or very briefly. And after episode on episode, they start to be able to communicate with SMS, but the communication with the phone speaking is only in very mild episodes. In other episodes, it's not the case. So we use a scale for measuring apathy during episode. It's a apathy scale that is used for other neurological disease, and that works very well in KLS. Are you interested in learning new things? Are you unconcerned? Do you have motivation? Do you need a push to get started on things like anything? Going to the bathroom, going to the table, all that during episode, the maximum of the scale is 42, and on average, our patients are 30, which is extremely high. We call that a total loss of autoactivation. And most patients get normal, back to normal during normal periods. A few of them have a mild residual apathy, which is much milder than during episodes. So the consequence of apathy is that 2/3 of patients eat less. They should be cold on the table or have a plate in their room when awake. Some are too exhausted to eat. They come to the family table, eat automatically, and then go rapidly back to bed. So patient may lose weight in an episode. It's not a big problem, but I say always check if they drink enough. It's effortful to go to the bathroom, so hygiene is often neglected. They should be pushed to the shower, but again, if it's every 2 or 3 days, it's not a big deal. Most patients have this apathy is also visible on the face with expressionless face, an empty gaze that parents are very able to recognize when a new episode starts. So nothing worse to stimulate the patients. So I always say no use to push them, don't push them. Let them rest until they tell you I'm able to do things. For the cognitive impairment, most patients are slow in answering, in speaking, their language is reduced, they do not initiate the conversation, you have to ask them questions and they answer with difficulty, yes, no, and sometimes just nodded. They seem lost, they have difficulty but if we have to sleep 22 hours, maybe we will be lost in time too, because you have not the regularity of life that go on during episodes. Sometimes they are lost in space. It's called confusion in terms of neurological term, and it's a big effort for them to think during episode. So no homework, of course. I usually write a medical certificate for the school saying this patient is affected by a rest disorder. He or she must rest in his bedroom and cannot work. Please excuse him and help him catching back the missed lesson after the episode. This is typically the certificate we write for patients. Now, communicating with them is difficult because of this cognitive problem and apathy. It's hard for them to be called by phone. They dare not answer their sleep. They do not want to see their friends. So some patients often prefer to communicate with limited language or with SMS. I don't know whether it's less stressful, but some parents organize that with their children. When they have to work, they send SMS, "Are you well?" and they wait for the answer. Due to cognitive slowness, of course, never drive a car during an episode. Of course, at the first episode, it's not a question of taking a car because they sleep a lot. But with time, with the decrease in the symptoms during episodes, some patients may be tempted to drive a car, but frankly, it's not a good idea because the reflexes are not good. For the realization, feeling and reason is found in almost 100 patients. It's the most disagreeable symptoms in all our patients. It generates some anxiety. They say it's like being in a dream, but I would say it's like being often with abnormal sensory feelings, like here, missing, let me write, I'm not sure that things are really happening around me. And there are some of them have blunted abnormal feelings, changing vision, in audition, in touch, in temperature. For example, the shower is an horrible experience as I see the water on my body, but at the same moment I don't feel it, or I don't feel its temperature. So some do not recognize themselves in the mirror, and they don't like to look themselves in the mirror because of that. They say it's not me, it doesn't look like me. And some will try to do something to get a normal reaction. So for this derealization, which is really a disagreeable symptoms, we have to reassure the patient, avoid novelty, keep them in the same environment, avoid going outside for shopping, and possible, we have a very little experience, not complete, but it's very simple to use, and it's to use acetazolamine, which is a diuretic that decreases brain swelling in over disorder, but it seems to decrease the realization during episode in our patient, and also it decreases the headaches, because the headaches they have during episodes are very poorly sensitive to paracetamol or to anti-inflammatory. So this is a cheap drug that can be prescribed by any doctor. So it might be nice to try it at least once. If you are sensitive to it, use it. There is no side effects. It's just going more to the toilets because it's a diuretic. So behavioral problems could correspond to disinhibition. It can be some gluten-free in 51%, sweets, or fixation on a certain food. Some patients want just some McDonald's food, for example, or just a specific food. But 40% of patients eat less during episodes. Sexual disinhibition is found in 30% of the patient, but it's not at all episode, and it's more in boys than in girls. Again, avoid contact with other people. It will limit the problems. Irritability and frustration of being in an episode, lack of politeness can be seen. Some patients have very childish regressive behavior or stereotype behavior. And when they are like that, some are excited and want to walk, and this could be a problem. It's not a lot of patients having that, But if they want to walk, they can go outside, and you have to look after them. So this is rare, but has to be supervised. Depressive mood is found more in girls than in boys. It's sadness, thought of death, suicidal ideas. Fortunately, there have been only 2 suicidal attempts in our patient, but unfortunately, 1 patient committed suicide. So please keep them at home under supervision. And if there is something very severe, call the hospital and protect them. Anxiety is seen in 51% of the patient. It's panic of being left alone, afraid of novelty, afraid that the disorder never stops, and the realization increase the anxiety. This is, for example, the SMS sent by a patient at the beginning of an episode. You can see the anxiety. Mom, 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 I'm afraid. Mom, please come and pick me. Hurry up, mom. You see the anxiety. It's in French, but I think you see it. So hallucinations are mostly brief. Delusive ideas like being megalomaniac or paranoia can be seen at 1 episode in 1/3 of the patients. So if anxious, check regularly mood, hug, appease, repeat them that it will end soon. Depressed mood is brief and frequently announce the end of an episode. Tell them that you are there for them and that it will stop. If it's too severe, we consider using a mild benzodiazepine like bromazepam or a sedative antihistaminic like hydroxyzine, because sometimes they are really panicked. If watching them is insufficient, bring them to the hospital for permanent supervision. We didn't find any efficacy of antidepressant at this point, possibly because the episodes are shorter than the benefit of antidepressant. As you know, antidepressant need 3 to 5 weeks to work. Then, because of all that, it's important to have a plan when the teenagers or the young adults go abroad or on a field trip. Sometimes it's not a big problem when an episode starts on a field trip, patients sleep, but if the patient is abroad alone, we recommend to have kept an assistant for being brought back home. We communicate with the medical assistant, we explain careless, and we communicate with the insurance and tell them usually pay them a simple fly back with somebody bringing back the patient at home, and it's sufficient. Don't bring them in the hospital. Rare cases need to be hospitalized abroad, especially when they are delusional, and beware of psychotic anxiety and delusion. But you have to make a plan each time somebody goes alone or on a field trip. The duration of the episode are unpredictable, but the majority of them is around 1 to 2 weeks, and they start, half of them start in a few hours and half of them in a few days. But as you can see, the mean episode duration is mostly around 1 to 2 weeks, but some patients have very long episodes. In the series of Stanford and in the series of Paris, we had 28% of patients who had episodes longer than 1 month. It's difficult to predict who and when that long episode will come, except if the first episode was long. This is more predictive that the other episode will be longer. So because of these long episodes that were not in the textbook before we did all this research program, we said, once an episode has started, is there any mean to stop it? In the past, we tried more amantadine, but results were not magical. Acetazolamine can help for, as we said, for headaches and derealization, but it does not stop the episodes. So when we start to have the first patient had an episode lasting very long, 4 months, so we decided with the family to try some IV steroid. IV steroids is what is commonly used in other autoimmune disorder, like, for example, in multiple sclerosis. And we made a case control study over 3 years. The treated patients were compared to a twice greater number of untreated patients, matched for age, sex, an age at KLS onset, and our patient had the mean 5 years of disease course. And we repeated the IV steroid in over episode in 29 of them. So the episode duration at the preceding episode was in those who receive IV methylprednisone was 30 on average, because of course it was a reason we use steroid in them. And using steroid, the current episode was shorter, 20 days on average. The control group who received no treatment because their previous episode was short, 10 days. So we do not recommend yet to use methylprednisone for those with short episodes. But at least the first, so it's significant, of course. So we compared the year 43 series, and it's minus 11 days. And if the infusion are made below the 6 days of the episodes, the efficiency is much greater. The success is 65% versus 25% if it's done after 10 days. So if you had a previous episode that was longer than 1 month and a new episode start, we recommend to start to try IV steroid. It's only 3 days of infusion. The first times we used to do it in hospital, but the other times we do it at home, which is much pleasurable for patients. And the chance of success are 2/3, and we didn't get any side effects. So except acute insomnia, of course, because the steroids are something that increase insomnia. So the infusion are well tolerated in KLS. The benefit is only when it's done in the first 10 days. We know from the neurological other example that we can repeat it 4 series maximum per year. We didn't find any benefit of it in the 3 patients who had evolved from an intermittent KLS toward a mild chronic form of KLS. These were patients who had continuous fatigue and apathy for the last 2 years, which is an evolution of the disorder that is fortunately rare, but extremely difficult to treat. So you can help your doctor by videotaping your child or during episode, or your husband, face, behavior, reaction, and keep a diary. This is very helpful. The diary we use has been made by some parents, and we put the episodes here and the date of onset, and for example, if they had a treatment, what was the dosage, and the treatment taken during episodes, the symptom severities. So each year we see the patient, we can have the diary and compare it to the previous one. So here it's for the symptoms. I hope I'm not too late. Oh my God, yes, I am. So could I go back to the question, the last one? I think there are many subtypes. Yes, of course, there are subtypes. So the best course of action to diagnose is PET scan in addition to symptom, yes. Is there any link to migraine? Before the first episode, he had bad migraine. So we didn't find the migraine is quite common in the general population. It's as common in KLS patients as in the general population. And the headaches they have during episode are quite different from migraine. They are more like tension headaches. It takes them the back of the head here, and it's really painful, but it's not beating and taking the half of the headaches head like migraines. Severe photophobia, almost everybody I have. I'm now 42 and I have KLS since I was 13, and I experienced a very gradual recovery during my episodes in the last 6 years. Yes, that's probably the mainstream is that the first episode are clear cut, I would say black and white, stopping in 1 day, starting in 1 day, stopping in 1 day. And with time, they might be more gray, less severe in terms of hypersomnia, but more extended with less clear beginning and ending. So it seems that, Harry, it's your case. I feel that is a blockage. That is something I read different Facebook. People, yes, for a week I am awake during the day and can much do than during the sleep. Yes, yes, you are affected during episodes. Okay. I think there are many subtypes in careless. Yes, there are subtypes. There are some with very short and brief and repeated episodes. And there are some cases with long but not very frequently episodes. I think that patients who are called careless are all different illness with similar symptoms. For example, COVID, flu, cold, allergy are all different illness but similar symptoms. Yes and no, it's quite homogeneous. What the common symptoms, the four commons are really commons to everybody: hypersomnia, apathy, derealization, and cognitive impairment. And the intermittent aspect is common to all patients, the age, things like that. But it does not mean that it's a different disease from a patient to another. My daughter's symptoms are so spot on with most of these during episodes. She's very high functioning, high achiever. Yes, fortunately, most patients go back to normal symptoms, to normal functioning. Here in Scotland, we have seen one neurologist one. We have never had any help for a careless doctor. Well, I don't know who in Scotland. I know there is somebody in London. If you want, I don't remember his name, but I can send it to Stephen. We're seeing a lot of patients for UK. My son has been in current care for 19 months now, and all the symptoms since he's 14. So Claire, hello Claire, we have already communicated together. Let's say to other that this is the exception rather than the rule, and we are all trying to find something that will help your son and a few other ones to go out of his. Jonathan, might later stage symptoms be similar in presentation to fibromyalgia? No, no. It's very different. Fibromyalgia is associated with some pain in the body that are continuous, and careless is not continuous. Brain fog and unrefreshing cognitive issue. This is the worst part in the episodes. Rajit, yes. Our daughter take clarithromycin. Yes, clarithromycin has been tried. It's an anti-GABA drug by the Atlanta group during an episode. If it works, they published it works the first time, but not the other ones. So it's always hard to make a deduction from a single patient experience to all over patients, because as we know, episodes may stop by themselves. So I would think that all what I told you, I've tried it at least in 20 to 30 patients before sharing my experience. It's not a single one. So beware that clarithromycin is not magical. Have you found any relation to hormone changes or menstrual cycle? A few girls have, at least at the beginning of the disorder, some episodes that are close to the menstrual cycle, but with times it does not recur with menstrual cycles. We have tried to give the pill for that, but it didn't change anything in them. So some boys also have episodes every month, so it's hard to say it's menstrual cycles. Monica, all the symptoms you talk are exactly what are, yes, your son has did, and he's got 45 episodes, he's now 22, and had no episode almost 2 years. It's so good to hear that and to read that. Thank you for sharing. I think it's important for the other families. We cannot say the likelihood of episode returning or not. In most cases, when it stopped during 2 or 3 years, it will not come back, at least if your son respect not taking alcohol or things like that. But there are some late relapse, we don't know why. Okay, MS, aplastic anemia and KLS, perhaps genetic links, I don't see which one. because MS is not associated with any chromosome. How can we get the IV treatment at home in US? Ask your neurologist. It's commonly used in multiple sclerosis. Headaches is squeezing your head. Yes, it's pressure headaches. You're totally right. Okay. Oh, Karen, thank you. It's Guy Lechinder in London for the Scottish family. Please read it. When I want to use amantadine, what is the best way to use it? We ask to start it as soon as you have the first symptoms. Some patients have some prodromal symptoms during 1 to 2 days before starting. So start it as soon as you have the prodromal. If it works, you continue to take it at least 7 days, and then you can stop it. Amantadine is an antivirus drug, and it also slightly awakens. Okay. Okay, so let's go. Do I have time for the residual symptoms? Yes. Okay. So
Isabelle, why don't we do this? Why don't you go through the next the
Okay.
rest of your slides just to be sensitive to the time, and then we can aggregate all the questions and
Yes.
find a way
Okay.
to get them to you,
Okay.
and we'll figure out a way then to distribute them to our KLS community.
Thank you.
To be
Plus.
functions,
Okay.
yeah.
Okay. So all what I've said before was known. We just specify things. What was less known and what we have discovered with following a cohort of 300 patients is what I will call residual symptoms, meaning that when I was young, we learned that KLS was contained episodes and normal periods, and that was the definition of the disorders. But after following up patients over now for 18 years, we discovered that after episodes, some patients had some mild, very mild, but sometimes disabling residual symptoms during asymptomatic period. A means that you should not have symptoms. So what is to be checked? Sleep, cognition, mood, anxiety, and adjustment. And it's what we do every year, and we see the patient not during episode, we see them during normal period, and we checked all that because that might be the problem. So about sleep time, patient declare sleeping longer than control, on average half an hour during non-symptomatic period. They go to bed earlier than control. This could be residual from episode, or it could be an adaptation to prevent new episode, because sleep deprivation can trigger episode. But we have an ongoing study on sleep. We monitor patients during 48 hours out of the episode and their circadian rhythm. And in the 40 last patients we did that, who all had recent KLS, we found a few abnormal things. Even if the boy or the girls were saying, I'm okay, I'm functioning well, I'm not sleepy, we found short sleep latency during daytime. We found also some rapid entry in REM sleeps, which suggests that there might be some mild tolerable things that patient can compensate by any way, because they are young, because they have a good brain. But there are some markers of the disorder staying between episodes, like an iceberg. There are some things below the level of the sea. We are looking for findings for a control group, so I don't know. It's hello to help because we are surprised by what we have seen. For cognition, what was known before, that there were individual reports of occasional cognitive difficulty between episodes, and there were some functional MRI done by the Sweden group, finding that some patients had altered working memory, and they were compensating by using different network in their brain out of the episode, which can be felt by some patients as making an effort. They can have some good results on cognitive tests, but to the price of a higher effort than before having had the disorders. So we look at that in our patients, 50% of them report academic decline, even in very well functioning persons. So we systematically, and now it's systematic, all patients got cognitive tests when they come, and we repeated them after 1 year in 44 in this report, and we correlate it with healthy controls. So it's basically attention that is checked for, verbal memory, spatial memory here. This is working memory, and what we found is that 15% of patients have impaired attention, processing speed, slower processing speed, and verbal retrieval problems, which mean that when they have to learn by heart some names of some words, they would lose some or have difficulty to access to 2 of them over 16. So because of that, and because most patients are young and they have to do some academic things, regularly check 1 per year the cognitive function. And if the child or the young adult have difficulty feeling of making an effort, also support them. We recommend to make a pause every 45 minutes to reduce the academic load. And in some cases, we recommend some cognitive remediation. In France, it's speech therapists who do it. It has nothing to do with speech, but they give them some exercise to improve. And we have now a good experience of using methylphenidate, not during episodes, but between episodes when needed, just after an episode when cognition is difficult to coming back, or when a cognitive effort is requested, for example, during test or academic test. And some patients, they tell me immediately, yes, it helps me or not. It's something patients know immediately if it works or not. If it doesn't work, stop it. So this is helpful in those who have problems. Now, the mental status during asymptomatic periods is important to look at, because on average, patients score almost as control do on anxiety and depression scale. Their psychiatric history, when we look back, is similar to what is seen in the general teenager population. When we interview patients and their parents, we found in 60% of them a history mostly of child anxiety, which is very common in the general population. So patients with KLS do not seem to have some psychiatric problem before KLS, at least in childhood and teenage. After KLS onset, we found that we follow them every year with a psychiatrist, and in between if there is problem. And there are some emerging psychiatric problem in one patient above 20%. It's mostly mood disorder and adjustment disorder. Adjustment disorder means that they are very anxious of doing a new episode, but this becomes really pervasive and a problem. This mood and adjustment disorder are what they found in 25 patients compared to 90, are more seen in women and girls, in those who had a high number of episodes and a long time spent in episode in the last years, and in those who have psychiatric symptoms, a lot of psychiatric symptoms during episode. So this gave some input on who is to be more supervised and follow up, mostly girls, frequent episode, long episode, psychiatric symptoms. So we ask for psychological support in this case, and really make it help patient to cope with the disorder. And of course, when there is a depressive episode, it has to be treated. And in this case, the psychiatrist gave her advice. Now, this is quite new. So is there any Q&A question about residual symptoms during asymptomatic periods? It looks like some patients keep some, maybe 5% of the severity of what they have during episodes, during non-symptomatic episodes. So about question, please continue. Okay, to put your question. So I will go ahead if you allow. What about preventing new relapses? It's what I did with the Stanford series here. You can see the years here of the disease course, and the teenagers appear in black here, and each time there is somebody decreasing here means that somebody has cured, as a remission of the disorder. We consider the remission as a I don't remember, I think it was 2 or 3 times the longest asymptomatic phase. It's always difficult to say that the remission is complete or not. I think in the future we should use rather 3 years without any episodes. It seems to be a good remission indicator. So you can see that all patients having start as teenagers remit, and the average, the median is around 10 years, as you can see here. It's extremely hard to predict anything for a given patient. These are average, median. So you might be here getting well after 4 years, or you might be here getting well after 20 years. It's much harder to say if the disorder will remit or not in those who start as child below 12 years old, and in those who start after 20 as adults. In this case, we cannot give even a median because we didn't find people, half of the group was not cured at time we did the study. So so what to do? Relapse frequently occur after an infection, so avoid infection. In the past, I had to explain what were the gesture to do. Since the COVID pandemic, I have nothing to say. Everybody know how to avoid an infection. We treat immediately any tonsillitis. We have quite a good look back at vaccination. Usual vaccination doesn't seem to trigger relapses. So we recommend to do the seasonal flu, because flu is definitively triggering episodes. And COVID vaccination, we didn't get a lot of relapse. At least we use mostly Pfizer, of course. But in the French cohort, we had no relapse after 2 first vaccination of COVID, and we had 2 relapse after the 3rd one, the booster, only in more than 300 patients. So it's very low. In contrast, we had some episode after COVID infection, not very frequently. So it seems to depend if you have a bad or not bad COVID, but COVID can trigger a relapse. So the general recommendation second is that some relapses occur after alcohol intake. So this is something it's possible to do by yourself. Stop any form of alcohol intake. I usually say at least 3 years, and really it helps avoiding new episodes. So keep sleep well, rhythm, excuse me, it's not rhythm, it's rhythm, sleep enough, of course, and have regular sleep and wake rhythm. So beware of eve, of birthday, graduation party, when alcohol, sleep deprivation, and close contact with infected person are combined. This is the worst combination to trigger episodes. So because the careless course is unpredictable, when considering to try a drug with the aim of preventing careless new episode, we have to check for baseline frequency and duration of episodes. So I usually don't start any proposal of drugs if I don't have a view on what have happened in the last 6 months or years, because if episodes recur frequently, which means 4 to 12 times a year, or are long, when an episode has been long, more than 1 month, or contain psychotic symptoms, delusional symptoms, I call that, these 3 things, I call that red flags. Too frequent, too long, or with psychotic symptoms, meaning that you have a risk of something severe. I think it is beneficial to try a drug, but anything tried should be reevaluated regularly, with the benefit on one side and the risk on the other side, usually after 6 months and then yearly. So because of that, this is our experience with lithium. The first try I published that was quite 6 years ago. We had at that time 131 patients in Paris. We suggest using lithium in 71 of them because they had one of the three criteria we said before, and 49 took nothing, and in 10 we tried valproate or contraceptive pills, and we compared the frequency and duration of episode before treatment or before attention, and after a mean 2 years of follow-ups. So this is the flow chart and the results. We tried lithium before suggesting lithium. The patient who will try it after had on average 4 episodes per year, and the one we suggest take nothing had on average less than 3 episodes a year. And at the second visit, 2 years after, both, so it's different of course, but this is not a randomized study. We proposed the drug when we thought it was more severe. And after 2 years, both groups decreased in terms of number of episodes, which is the usual way of the disorder to evolve, but it decreased much clearly from 4 episodes a year to 1 episode a year under lithium. And the duration of episode also decreased here. So at the end, for this, and the side effects were expected with lithium, some tremor, some need to drink and go to the toilets more frequently, diarrhea, and more apnea. But the result is synthesized here. We have 87% of responders. We call complete responders 1/3 of the patient, those who have no more episode under lithium, no more, 0. And partial responders, it's half of the group. Non-responders still exist. In these cases, we stop the lithium. Under lithium, 9% of the patients have what we call mini episodes, like an episode is starting, they still feel during half a day or a day the symptoms, and then it does not develop, as if the lithium was stopping the beginning of a disorder. And it's something I rarely see in non-treated patients. Then 13 patients had an episode, a relapse, after stopping lithium for 2 consecutive nights, which suggests that decreasing rapidly the dosage in the blood trigger episode. So it's not the high level of evidence, it's what we call level 4. Level 4, the higher level of evidence for a drug is when it has been tested versus placebo in a double-blind manner in the same kind of patient. This is hard to do, but in practical experience, lithium is 1 month less in episode per year, and the lithium level should be high and monitored. So acetazolamine, I told you, as a prevention, it can help during episode, but in prevention of episode, I tried in 3 patients without success because there was 1 published benefit in the literature. Valproate may help. It's our first choice in boys with a mild KLS, but it's forbidden now in France in girls, as it is deleterious if she is pregnant. And there is a lower level of evidence than lithium, but it's simpler to take, only 1 dosage to do, so it can be tried first. And contraceptive pills, as I said, no clear preventing effect, but it's worth trying because they are teenagers in case of sexual disinhibition, and if we want to decrease the fatigue that is linked with menstruation in girls. So what we have learned in the last years, that it's important to check every year for long-term cognition impairment or psychiatric health during asymptomatic periods, and we should put in bracket asymptomatic. Support if needed. During episodes, long episodes, consider IV steroid, not short one. Prevention, it's open large controlled study showing the benefit of lithium therapy, and we treat patients with red flags, long or frequent episodes, psychological symptoms, psychotic symptoms during episodes. So I think I'm over. I really thank the foundation for their help. I've been helped also by Careless France. I don't know if you guys want me to answer question or if it's too late. Tell me.
I think we're approaching to an hour and a half here, so I just want to be
Yeah,
aware of that
yeah,
time.
yeah.
Again, I'll collect all the questions and make sure that we
Yes,
get them to you. And
I
the
can.
reason we're doing this is
Yes,
to give people the opportunity to ask questions and get your
yes.
perspective. So we will ensure that that happens.
Mm.
Maybe we can leave off with just one question. I mean, this is a tremendous look back of all your observations and your
Yeah.
research to date. Can we, like, what is your group or your department? What are you currently working on, and where do you think KLS research is
So,
going to be carried out in the coming years?
Excellent question. I working in many directions. First, on the mechanism, I'm exchanging a lot with the French neurological autoimmunity group of Jérôme Honorat. I send him also some sera of patient, and we keep in touch very often, so that each time a new autoantibodies is found, I'm checking it immediately in our patients. So I think the autoimmunity is a good way to look at. I was disappointed, of course, by the lymphocyte phenotype. We could do it as a clinical way because I'm in a university hospital. That was a lot of money, and we didn't find anything. But I want still to go on this direction. I want to try ketamine during long episode. I know some guys in US have some experience. Ketamine is the drug used during resistant depression, and it's now used in psychiatric department. So I want to use that. And also, as I told you, I'm looking on residual symptoms, and especially the circadian and sleep symptoms between episodes. And I think there are some, at least in my first 40 patients, there is some abnormal things there. And I wish, I'm 60 years old now, so I will be obliged to retire in 7 years. So I said in myself, I want to find the cause in the next 7 years. That would be so great. Okay, so that's what I'm working on right now.
Great, thank you. Well, that's an excellent ambition, and we hope we're all here to see that success. Before we just close, I just want to thank you, profusely for sharing all these observations and your research with us. You have been an invaluable partner to the KLS Foundation for a long time, and we look forward to continuing to support your efforts to find breakthroughs in KLS. So thank you. For everyone that joined, thanks for caring and making the time. I mean, scientific research is a long process, and as a foundation, we just want to stay in front of you and engage with you to let you know that there is activity, and we are working on trying to find answers. So I'll collect all additional questions. Isabelle, thank you for being willing to review them, and we will redistribute them at some point in time. And that's it. We'll be back in the fall with another update from the lab in Stanford. And until then, I hope everyone stays well.
Thank you very much. Goodbye.
Thank you.